Okay, why don't we go ahead and get started? Want to welcome everyone actually to the inaugural, to the kickoff meeting for our research conference for this academic year. And our speaker is Dr. Art Papier, someone I've known a long time, and it's been interesting for me to see his ideas and his company develop. This actually is not the first time he's been here. He spoke in this room probably about 10 or so years ago. Whenever, it's mostly the dermatology folks that get him out here. He's a dermatologist, as I'll explain in a moment. There's actually a big dermatology conference tomorrow. One of the topics on it is diagnostic errors, which are not uncommon in all aspects of medicine. And he'll be talking about that tomorrow afternoon. You can find out more about that. It's the Fran Storrs lecture, and it's on the dermatology department website. But when Art told me he was coming, I said, you got to spend an extra day and spend time with our department, which is what he did when he was here last time. So Dr. Papier is a physician, trained practicing dermatologist, developed an interest in point-of-care tools, clinical decision support, and has developed this system, VisualDx, which is not only on those computers, but also on my phone. Not that I try to make any diagnoses with it. And he's, in addition to being the founder of his company, which he'll tell us a little bit about, he's also on the faculty at the University of Rochester Medical Center in New York. And so I explained to him that there's a wide variety of background and interests here. There are those of you studying bioinformatics, clinical informatics. Some of you are physicians. Some of you are PhD students or postdocs. So it's a real mix, and it's actually good to see that. So anyways, I will turn over to him. And one other thing, the kind of formal presentation part will go for an hour, and then he's agreed to stay on another hour in a more informal presentation. We geared it. It's billed as a student event, but anyone is welcome. So after about an hour, when he finishes the talk, we'll take a short break and let those who need to go other places leave. And then he'll be happy to answer your questions, what it's like to start a biomedical informatics company and so forth. So I will turn it over to him.
Well, Bill, thank you so much, and it's a pleasure to be here. And let me just start with my disclosure. I'm the CEO. I'm a shareholder of this company. And what I want to do with this talk is begin by framing up problems and kind of give an overview and then kind of narrow down towards diagnostic decision support. But I think you need to be really clear about this idea of what is decision support. And so this is from Chuck Friedman, who made this graphic where he's basically we're saying the brain plus the computer is more powerful than the brain alone. And I have machine learning, AI of any kind, rule-based systems, any type of technology I'm putting in that bucket of computer. And so the media likes to frame this as man versus machine. We're going to replace the doctors with computers soon. It's really kind of sexy for the news media. But really, most people believe that we're talking not about artificial intelligence. We're talking about augmented human intelligence, like having tools for people. And this is really the story of my professional career. I went to med school in the 80s, and when I was in med school, there were no computers being used, and there were obviously no smartphones. We had this stuff called film. The young people in the room don't remember that. But it was really different, and it's not that long ago. But we were really memory-oriented and had unaided decisions. The most you had maybe was this thing called the Washington Manual shoved into your white coat. And you had scraps of note cards with calculations and formulas. And when you went on rounds, that astute professor wearing that white coat had miracles of knowledge that they would try to impart on you and model for you that you needed to fire back answers. So the idea was that you would have answers for the professor, and you certainly would hide your doubt from patients. Where I think we're moving now to be more process-oriented, have assisted decisions. Certainly all the students and residents have smartphones, and they have apps that have calculators in it. And they have, this started really with the Palm Pilot. How many people remember the Palm Pilot? So Hippocrates was that first drug checking app, and that really, to me, was like the birth of doctors using point-of-care computer tools widely, was Hippocrates. And then since then, we've moved to these great smartphones with lots of apps that docs are using. And when we're in clinic, when I'm with my residents, I try to model for them information acquisition. So as an example, I had a resident say to me 6 months ago, we have a patient in room 3 that I believe has vasculitis. And I said to the resident, well, why do you say that? She says, well, there's palpable purpura, which is a sign of vasculitis, on the exam. I said, great. Okay, well, what's the cause of the vasculitis? And she said she didn't know. And I said, well, let's go through pathophysiology of vasculitis. Let's do categories. Is it infectious? Is it collagen vascular disease related? Is it medication related? By the way, what meds is the patient on? Now, she wasn't really sure. I said, well, you really shouldn't present until you really know that med list and when meds were started and stopped and which meds potentially could cause vasculitis. Because you were saying to me, you believe the patient has vasculitis. Well, why? You should look it up. Don't present to me until you check those meds in a database. And I don't care if you check it in a book or in a computer, but you need to look it up and use data to inform that decision. And that's very, very different than just operating out of your brain when I was in med school, where the professor would just say from their brain and there wasn't any looking up. So modeling information acquisition, I think, is a really important part of teaching now. And then, of course, shared decision making. We don't have the kind of paternalism that we had in medicine 40, 50 years ago, where doctors always knew best. So at our company, we're really thinking about this problem of diagnostic error. So there was a report in 2015 by the Institute of Medicine, now called the National Academy of Medicine, Institute of Medicine, that had this quote that nearly every person will experience a diagnostic error in their lifetime. So that means all of us, me included, all of us in this room will probably go to a clinician and have a diagnostic error happen. And we created this infographic to kind of highlight that this is a problem that's really been under the waterline in medicine. So Bill remembers, like, the early days of decision support, we were really talking about diagnostic tools 40 years ago or whatever, 30 years ago. We really weren't talking about some of the new definitions of clinical decision support. People were focused on diagnosis, particularly in internal medicine a while back, but over the last 20 years, the quality and safety movement is really focused on things like wrong site surgery, hospital infections, dosing errors. So medication and surgical errors are newsworthy. Like when the wrong limb comes off, it hits the newspapers right away. Or a dose, like Dennis Quaid's, the actor Dennis Quaid's newborn twins were given the wrong dose of heparin and almost died. That's in the news. So the public really thinks that's happening a lot. But really the mass of the iceberg is 74,000 deaths a year attributed to diagnostic error. And a little plug for a meeting, if anyone gets interested in this, there's a meeting called the Diagnostic Errors in Medicine meeting that's this year will be November 4th to 8th, I think, in New Orleans. If you get interested in this field, it's a meeting of researchers and educators and physicians of all specialties. So this is the area that we're really focused on. And we created this infographic from a malpractice liability company report where you see diagnostic errors are higher than surgical errors or medical management lawsuits or medication lawsuits. So that all the liability data points to that diagnostic errors are a significant problem. And in this National Academy of Science report, there were 8 recommendations, and this was goal 3, ensure that health information technologies support patients and healthcare professionals in the diagnostic process. And that's just some more liability data where diagnostic-related harm outpaces all the others. So in terms of thinking about this healthcare system, I'm kind of curious for the clinicians in the room that are here at OHSU, is there any planning going on to improve diagnostic accuracy that you've heard of, like in M&M context? It really is probably, it's on the radar here at all? A little bit, you think? Yeah. Speak up again. Yeah, I mean, that's, yeah, sure. But broadly, when I go around and I give talks like this, usually very few hands go up. That it's really not on the center stage of quality and safety at most institutions. So another problem related to diagnostic errors is this problem of clinical variability. So, you know, clinical decision-making and diagnostic variability hasn't been this focus of how we drive high reliability into decisions in the healthcare system. And we believe that we need to start to develop universal information platforms that can really start to reduce all that variability. Okay, so how do doctors do their thinking? And let me ask how many have read this book? Okay, so this is a great book, and if you go to the talk tomorrow, I'm sure it'll be referenced by the other speakers there. Daniel Kahneman's a behavioral economist that won a Nobel Prize, and he wrote this wonderful book explaining System 1 and System 2 thinking. And so basically, here we go. And let me pause and ask how many people read this, called Blink book by Malcolm Gladwell. So this is an explanation of System 1. So let me explain System 1. You can't keep the answer out of your brain. It was instantaneous when you saw this. And you can't keep what this structure is out of your brain. It's instantaneous. So System 1 is that blink moment. It is the ability for the brain to instantaneously recognize a pattern. And in this book, Blink, Malcolm Gladwell talks about how out of the corner of their eyes, pilots can recognize, a fighter pilot can recognize something that might be harmful. And it happens near instantaneously from experience. Now, System 2, how many know the answer to this? It's not a blink moment. So you have to use that front of your brain there to start thinking about it and analyze it. And who knows the differential diagnosis to this? It's not a blink moment, right? You have to start thinking about it. So that's System 2 as well. So our brains are shifting between pattern recognition, System 1, and thinking, System 2. What do you think the brain prefers? What do you think we're really designed to do, System 1 or System 2? The brain really, in Thinking Fast and Slow, he lays out the case for Dr. Kahneman of why we prefer System 1. System 2 uses a lot of glucose. You're going to go, when you're studying for an exam, you're going to that refrigerator a lot because you're burning a lot of glucose. System 1 is a lot more efficient for the body. And there's great explanations in this book, Thinking Fast and Slow, for why the brain prefers System 1. And so this book has really been the basis for this work in this field of diagnostic errors, where he lays out all the different types of cognitive mistakes. And Dr. Crosscarry, who's speaking tomorrow, who's an emergency physician and psychologist, has written many papers on definitions of all the different types of cognitive mistakes we make as clinicians. And I'm sure some of you have heard of premature closure, like coming to an immediate conclusion and not building out that differential diagnosis, or anchoring. having a diagnosis maybe from another physician and not moving off that diagnosis to step back and reconsider the diagnosis, overconfidence, et cetera. And there's about 30 of these. I'm really interested in this cognitive mistake called representative bias. So this is the idea that there's a lot of variant presentations. So if I said to patients in the emergency room, they come in, they have crushing chest pain, they have pain down the left arm, they're sweating, and they're fatigued, anybody that watches television knows to think of a myocardial infarction. That's not difficult, right? But the patient that comes into the ER who's 70 years old and says, I got the bad toothache, right? And gets triaged to the non-acute side and doesn't get diagnosed with that MI, that atypical presentation of the MI is what's causing a lot more harm than missing super rare diseases. So one of the themes I'll keep coming back to is that variation of the common causes a lot more harm than missing really rare diseases. And so we created an infographic. So this is 20 patients in a day, and the research from the National Academy of Sciences is saying probably 2 are going to be wrong. And so on the left it says a patient in red presented with headache, diagnosed tension headache, did not realize workplace exposure to carbon monoxide. So the doctor asked some questions and of course didn't say to the patient, well, where do you work? Patient works in a warehouse. They have propane forklifts that aren't tuned correctly. The patient's breathing carbon monoxide and gets headache. You'd have to know to ask those questions if you're the doc. But in a fee-for-service system where we're seeing 20, 30, 40 patients a day, right, the question is, can you really bring all the knowledge to bear to that decision-making moment when that patient's in front of you? And so the other one says dizziness, diagnosed benign positional vertigo, missed cerebellar stroke, and it was an anchoring error. So there's these different reasons, and you can easily imagine in this really fast-paced environment of medical practice in the USA today and in your emergency departments, how difficult it is. If you're an emergency physician, there's probably 500 different chief complaints that you're trying to evaluate as an emergency physician. And you have to shift between, an orthopedic injury to chest pain, to motor vehicle accident, to rash, to dizziness, and do that just out of your brain, right? So the question is, what are the tools that can help that brain? So another example of diagnostic error that's been a focus of my research is this problem. So this is a patient that had 3 hospital admissions in 6 months for this rash on the legs. And you see the pen lines that the emergency physician has drawn around the redness on the legs. And they usually do that because they're concerned about the extension of an infection, and they're looking to see if the infection is ascending, as in cellulitis. So these were 3 admissions for the wrong diagnosis. And research that we did in Rochester, pooled with data from Harvard, UCLA, showed that 28% of 145 consecutive admissions were misdiagnosed. In the UK, of 635 cases, 33% were misdiagnosed. And so there are over 500,000 admissions for cellulitis in the United States each year. And if you get it wrong, you're admitting these patients, they get IV antibiotics, and you're giving them ordering unnecessary lab tests. They're in the hospital often for days, and you're putting them at risk for C. difficile infection or MRSA or a drug reaction. When you do the math, if you assume that you can reduce the error rate from down to, you need 10% probably false positives. You're never going to get rid of all the error. But if you assume that you can improve it by 20% of the errors, you have over 100,000 errors, admissions that are unnecessary, which is over $1 billion in the U.S. each year spent on people being in the hospital for cellulitis when they do not have cellulitis. So that's an example usually of premature closure. The red leg is immediately assumed to be infected rather than considering other possibilities. So how did we get here? So here we are in 2018, and we have these problems in healthcare that are very large. And we think about where this started. So this is a copy of a medical record from the 60s. And, you know, it's illegible, right? But that's not really the main problem, it being illegible. Dr. Weed, who's heard of Dr. Weed here? Quite a few, great. So Dr. Weed is the doctor that came up with the idea of the problem-oriented record and SOAP notes. And what he was saying about this record wasn't so much that you can't read it, which no one could, but that it was disorganized, that there was no common format in healthcare, in medicine, for charting a patient note. So you could go into one doctor's office and it would say the date, Mr. Jones, and then it would say pneumonia, and it would say penicillin, 250 milligrams, QID times 10 days, and that was the entire note. And you go to another doctor's office, and it was a different style to a note. So he came along and said, these unstructured notes are a reflection of poor thinking. And he says, we need to bring consistency to thinking. So this idea of SOAP brought forward this idea that you need to take a very thorough history and get the subjective. You need to do an incredibly thorough physical exam and gather other objective data. You need to do your assessment and think through the possibilities and then create your plan. And when you have that problem list, in the problem list, if you don't have a basis for why you're calling the symptom of, trouble swallowing, hiatal hernia, if you don't put hiatal hernia, the diagnosis, in the chart until you have a basis for the diagnosis. So many of you work in the hospital, you work with Epic here, right? And so do you maintain your problem list well? Is that a problem here? Unmaintained problem list? In medical informatics, everybody's talking about how we can't keep the problem list up to date. But one of the things I've noticed about the problem list has really gone backwards to becoming a past medical history list. And so Dr. Weed said, a problem is a problem until you have a basis for a diagnosis. And when I look in our Epic records at Strong Hospital, I never see in the problem list unexplained vomiting or unexplained headache, an actual symptom problem. What you see usually is just a list of diagnoses, which means that all our clinicians are great diagnosticians because the problem list just has diagnoses. But Dr. Weed was saying you keep that as a symptom, a chief complaint, until you have a basis for the diagnosis. And if you don't manage it that way, you're encouraging anchoring. You're encouraging people to pass along the myth of the diagnosis. So he railed against this idea that we could move information from books and journals through the brain and be accurate. That was something that he spent his entire career railing against. And for those that never heard him speak, there's this wonderful 1971 internal medicine grand rounds at Emory that we put up on YouTube on the web. And if you just Google Larry Weed, Grand Rounds Emory, YouTube, you'll find it. It's really a wonderful talk that he gave in 1971, and it's still valid today. So let's see if we can get this thing to work.
What you're doing. Now, what I'm saying is that a doctor has to be a guidance system. He is not an oracle that knows answers. And once he accepts the concept of being a guidance system, then he knows that the data system is the basis from which all his work must take place. And good medicine is a careful, rigorous, inching your way towards a more and more secure position. A final diagnosis is a myth.
maybe there's something wrong with the way we're running the whole operation. Memorize, regurgitate, forget. Memorize, regurgitate, forget.
There's 500,000 deaths a year from mistakes in medicine. Where's the outrage?
So in the 70s, Dr. Weed computerized a floor of the Fletcher Allen Hospital in Burlington, Vermont. And so I guess many in the room weren't born then, but anyhow, these computers were these basically like green screens that had up and down arrows. There's no windows, there's no mouse. You just had up and down arrows and a keyboard, and they were all terminals that would go to a mainframe. And the mainframe would have probably a room about half the size that was 50 megabytes of storage or something like that. So think about this. And by the way, you could smoke a cigar as you were working back then in informatics. If you're an informaticist, you had your stogie, I guess. But anyhow, so they were working on computerizing a floor of a hospital in the 1970s. So it didn't go well. You know, it's still hard to get doctors to use an EHR, but you can imagine in the early 70s requiring order entry through a computer and how slow that was. And there's Dr. Weed working in the Promise Lab. He had tens of millions of dollars of federal grants to develop this. He's just way ahead of his time. And then so by the 80s, we had several of these diagnostic support systems evolve, and the students here probably will spend a day on this or some learning on these systems. Internist 1 by Jack Myers out of Pittsburgh that became Quick Medical Reference, and Iliad out of Homer Warner in Utah, and D-Explain from the MGH lab. D-Explain is still available. You can play around with that, I think, on the web. You can find D-Explain. And PKC is what Larry Weed invented, problem knowledge couplers, which is no longer available. And this is a screenshot of D-Explain. So you enter symptoms in the center, and you get common diagnoses on the right, and down below rare diseases, and you can refine it by it asks you more questions. So the question is, after 30 years history of creating diagnostic support, what do most physicians use today? And I'll tell you, this is what most physicians use. They just expediently go to Google and they search some symptoms in Google. So the question I ask you is, would you get on this plane if your pilot only had Google to navigate? I don't think anyone in this room would get on this plane. So pilots have instruments, and the instruments are developed and designed for the tasks of taxiing, takeoff, flight, landing, and taxiing. Those instruments have a purpose they've been designed for. Google has one algorithm. Everything goes through the same algorithm at Google. And it really hasn't been developed for putting symptoms in and getting a differential. So we've been thinking about at our company this idea of like what is the ideal cockpit for clinicians? And our mantra is that it takes the number of ingredients and real purpose in the development. And so we've been working for years on a standards-based medical terminology. So we have a relational database mapping terms and concepts in our database to SNOMED for diagnoses and findings, and RxNorm for medications. And we use that terminology to build a knowledge base. And so we're building a findings to diagnosis knowledge base where we're using the medical literature to build this foundation based on, for instance, if you travel to Kuwait, what infectious diseases are you at risk for? So we actually have medical librarians that are reading WHO and CDC reports on where infectious disease is moving around the globe, and we put this in a database. We've done the same thing for probably 15 years with case reports on medication adverse events. So we're not just relying on the initial trials for the medications, but we're using post-release of the drug, looking at all the case reports in PubMed. So you have the standard terminology, you develop a knowledge base, and then you start acquiring images. And so it's our belief that that pattern recognition piece of System 1 is a very important part of problem solving, and we need to enable that we just can't give lists of words. We have to think about visualization of data. And so we put this all together. We've merged this terminology, images, this knowledge database, and more recently machine learning on the images to deliver answers at the point of care. And so this is a graphic of the typical kind of result that you would see in a diagnostic support system, like I showed you in D-Explain and others, would give you a list. And if you didn't know what a disease is, you'd have to click it and go read it and hold it in your brain, go back to the differential, read about another diagnosis, and hold it in your brain. So our approach is visual, and beyond the pictures of rashes, you'll see some diagnostic imaging, and then you see these diagrams. So we've created this idea of the symptom icon, which we call the sympticon. And the sympticon here is, it's probably hard to see in the back of the room, but it says cubital tunnel syndrome. Now, if I gave you a page of text on cubital tunnel syndrome, it would be hard to immediately know from that page of text, where is it, where's the distribution, what are the symptoms? And so the goal of the sympticons is to put into an interface the ability to see the key findings of a diagnosis so that when you have a differential, you can compare between the symptom patterns. And so this is a graphic of two different searches of the same disease. And this ties into the assertion that variation of the common causes more harm than missing rare diseases. So in this side, there's been an entry of facial palsy and arthralgias, and it finds at the top of the image stack Lyme disease. In this other search, someone searched rash and target lesion, and because rash was entered, the system knew to put a picture on the top. So the idea is that Lyme disease can present many different ways. Some people say they never saw a rash. Some people didn't know they had a rash. It was on their backside. It came and went. 6 months later, they present with facial droop, arthralgias, or they present years later with neuropathy from more advanced Lyme disease. So Lyme disease can present many, many different ways. And so what we've done is in this interface, we've stacked all these pictures and diagrams to show different phases. And depending on which findings you enter, it flips these pictures around as it builds the differential. Another feature of what we're doing related to variation is there's been bias in knowledge in medicine. And so the books, back when people used those things called books, were really skewed towards atlas of disease in people with light skin. So since the beginning of our company, we've been very purposeful of saying we want to represent disease in people of all colors. So in our interface, you can click on the right and choose between the Fitzpatrick skin type 1 through 6, and then it will flip you and show you the rash presentations in people of color or just light skin, however you want to present it. And there's another shot of the sympticons. From an informatics point of view, the greatest challenge for us is not the technology. It's building awareness that this tool is available and getting doctors to use it. And so the system is now in 2,300 hospitals and large clinics, and there are over 90 academic centers that have it and teach with it to some degree. And I say to some degree because there's also variability, not just in clinical variability, there's variability in how we're teaching about tools and how we're using tools. And so this is really a cultural problem more than it is a technical problem. And so it's our belief we have to get into as many workflows as possible so that the clinicians will start to take advantage of the information. So VisualDx can integrate into the EHR using either the HL7 info button standard or the SMART and FHIR standards that are now evolving. And it also is used on a smartphone with Android or iPhone. You can use it on either device. And we integrate it as well into UpToDate. So you can be searching in UpToDate and see a VisualDx result in the search results of UpToDate. So we've worked very, very hard to get VisualDx visible, but still medicine has one foot in that 20th century of memorization and the other foot into something future aspiration of using evidence. And we are all living through this transition from this memory-based paradigm to a digital paradigm and an evidence-based paradigm. And so that really is, we can talk more about it during questions and answers, but it's certainly a challenge for us. So here's a screenshot of Epic, and this is our quality and safety use case of your clinical question is the medication causing the problem? And so what we've done is we've engineered it so you can right-click on the med, and it will send the med code up to the cloud, to our server, and then we'll send back to Epic the drug reaction differential inside Epic. I do not know if this is turned on at OHSU. It takes about 30 minutes to be configured. Epic's using this standard, we're using this standard. But I just don't know. We'll have to look into it to see if it's turned on here. Anyone know? Now, there's a real informatics issue here. This is a really great sub-story to this. This is using what's called the HL7 info button standard. Well, Epic took the info button out of the standard. You have to know that you can right-click on a value like a problem in the problem list or a med in the med list, and then you run this search called active guidelines. Now, at our institution, we've had this turned on for 6 years, and I'm still showing it to people. Like, oh, when did you add that? 6 years ago. So here's a problem of design where Epic, in its infinite wisdom, took the info button out of the info button standard. The info button's a little iconic eye that would sit next to a value that you would know that's a signal that you can operate on that value to get additional information. So it's no surprise that most people don't know, most doctors don't know that they can right-click to use clinical decision support right in the record. And here's a screenshot from Cerner using the HL7 SMART on FHIR standard. We went one step further where we can pull from Cerner, and we'll be doing this with Epic soon, the begin and stop dates of medications. And one of the challenges in the hospital where you have a patient that's on 10 medications and your clinical question is which med might be causing this problem is you want to recognize when meds were started and stopped to see the temporal relationship between the medication and the new symptom. And so we can pull the start and stop dates and then represent graphically with a timeline when meds were started and stopped. And same thing, the drug reactions inside of Cerner. So I want to segue into machine learning. Everybody's probably heard about machine learning in the room. Is that a fair assumption? So there's a tremendous amount of news on machine learning. It's certainly a tsunami of activity, of interest and research and progress that's advancing way faster than most people thought it would advance, and particularly around the imaging specialties. So radiology, dermatology, ophthalmology, you just keep seeing these press releases. There's just a machine learning approval by the FDA for diabetic retinopathy. And there's really some compelling research. There's also a lot of hype. It sounds like, that doctors won't exist in 5 years based on some of these news reports. So here's a picture of a pediatrician in Rochester taking a picture of a child with our machine learning app, feature of our app. And here's a photo of Dr. Brown. Dr. Brown is the chair of emergency medicine at the University of Maryland in Baltimore. And this was really a great example, and I'm hoping I can get my iPhone up to show this to you in real time. So this patient came into the ED and told the resident that she had a lesion on her finger 2 weeks earlier that was hanging by a stalk. So the patient tied a string around it and ripped it off. And she told the doctor that it bled like crazy, and then it came back that much larger. So this is when she shows up in the ER. It's now larger than where she started 2 weeks earlier. So the resident didn't know what it is, and then Dr. Brown came in, and he didn't know what it was, but we had licensed VisualDx, University of Maryland. So he said, oh, I got this new app. So he takes a picture of it, and I'll see if I can recreate this, because he sent me the photo. All right, so what he did was he turned on the camera in the app, and he took a picture, and here's the picture stored in my camera roll, and then he clicked Use This Photo. And it says Analyzing Photo. I don't know why there, let me go off of it. There we go. So on the bottom, there's 3 icons. The left says friable papule. The center one says skin ulcer. The third on the right says skin erosion. So he's looking at these. He says, yeah, I think that's a friable papule. I'll agree with that. So he clicks that. He hits continue, and then he types in finger. And then he hit view results, and it gave him a differential with these little pictures. So he's looking carefully at these pictures, and he sees the second one down's a finger with something that looks really bloody. So he got curious about that. The resident was standing behind him, and he was doing this in the exam room with the patient watching him do this. And so he clicked the picture, and he started swiping with his finger, and the resident was going, huh? And he told me there was no interchange of words. They were just looking at these pictures, and he's just doing this. And he got here, no, I think it was this one. He got here, and then he enlarged that. And he said, wow, that really looks similar. And then he went over and read about it, where it says pyogenic granulomas are rapidly growing. And the patient watched him do this, and he said, I think this is what you have. I'm not sure. We're going to refer you. It says it's benign. We're going to refer you. And then he texted the image to the dermatologist, who responded the next day and said, hey, Dr. Brown, impressive. I didn't think you'd nail that one. So this is a great example of pushing skills down to generalists. So if we go in and we say, sorry about getting text here. Let's do one more. So if we say, take this lesion in the ear and say, use this photo. It says cutaneous horn, thick scaly papule, callus. So there's 80 different skin exam morphologies that we've trained the machine learning to. So what it's doing is not going directly to the diagnosis. We're asking the user to confirm whether they think that's what the lesion type is. And what we're really interested in studying, and this would be a great project for a fellow, is this idea of machine learning to enhance skills, not to de-skill. So there's been quite a bit of conversation in the last 5 years in general about AI in society de-skilling people. There's been some studies of pilots where they're saying pilots are using the autopilot so much that they're using some of that tactile learned skills that the older pilots have. And, you know, this thought that if we had self-driving cars all the time, that people wouldn't have the skills that they really need to drive in snow or whatever. So with this model, what we're doing is we're presenting the rich vocabulary of dermatology to the non-dermatologist. And this is a real key to accurate dermatologic diagnosis. You have to categorize that physical exam well. So if you can look at a patient and a resident or student says, Dr. Papier, there are grouped umbilicated vesicles, I already know they're thinking about a herpetic infection. So you have to do better than saying it's a rash or it's a lesion on the finger. So we're very, very interested in, can we use machine learning to prompt the physical exam terminology, and will primary care doctors and ER doctors start to do better and learn this terminology? So that's the professional app. And I'll just, while I have it up, I'll just quickly show you. It's not just machine learning. Like you could go in and say, let's pretend. We'll pretend that the patient here who had this lesion on the finger, and we use it. So you've analyzed someone's lesion. And this time we'll do an ulcer. And we go ahead and we say ulcer in a traveler to Kuwait. So I put in the patient went to Kuwait, and now I hit view results, and it's showing me brucellosis, old world cutaneous leishmaniasis, and cutaneous amoebiasis. So this is an example of bringing together that knowledge base with the machine learning. So we don't think machine learning is going to get you to diagnosis, because there are a lot of other factors that we leverage in diagnosis beyond the image. You know, in dermatology, there are those system one blink moments that's Malcolm Gladwell's describing, where the patient comes in and dermatologists need no history. They just say, that's a basal cell, or that's psoriasis, right? And the patient that comes in, say, with pink spots all over their body, and I have no history. I don't know if that's a drug reaction. I don't know if they've traveled and they have chikungunya virus from traveling to Central America. I wouldn't know until I asked some questions. So part of our strategy is to put machine learning together with this knowledge base to deliver better answers at the point of care. Now, the other part of machine learning that we're working on that we're really excited about is a new app that you all can download. It's free right now, called ASA. And let me go back to the beginning. And hold on, start. So ASA, we've been working on this for over a year, thinking about how can we deliver to people on their smartphone the ability to triage themselves better than going to, say, Google or WebMD. And so the idea, let me start right from the beginning and start the app. So you download the app for free from the App Store. It says, what is ASA? A guide to help you answer questions about common skin conditions. Well, ASA covers over 200 conditions. This is only a small part of medicine. ASA doesn't diagnose. Only trained practitioners can do that. When in doubt, have your healthcare provider check it out. And so you understand, and then it says start a new case, and you turn it on, and you take a picture. All right, so I'm selecting this picture. Now, this picture was given to me by our product manager for ASA. So our product manager for ASA was at a wedding about 3 weeks ago. He sees his cousin. His cousin says to him, Joe, I hear you took a job with a dermatology company. I have a rash. She puts out her hand at the wedding. And he says, I have this app. Yeah, so I do work for a dermatology company. So he takes this picture, and he hits use this photo. And now it says, it doesn't say medical terms like friable papule. It asks in lay terms, is this a flat, smooth area of skin larger than your thumbnail that's darker than normal skin tone? And he said yes. And then he set up a profile for her where he put in female. I'm not going to do that now. We'll say it was on me. And you have to decide whether it's a single little focal lesion, it's a rash somewhere, or it's all over the body. So he chose the middle one. And then it asks you where is it, and he selected it was on the back of the hand. And then he hit continue, and it asks, how long have you had the condition? And he said she had it days to week. And then it says, does it itch? He said no. Do you have a fever? No. And then it tallies up all the responses, and then you hit show results, and it shows a bunch of different matches to the scenario you put in. So he's looking at this. She's looking over his shoulder. And the second one down said Lyme rash. So he clicks that, and he starts swiping through with her looking at the pictures. Now, this is all system one, right? This is all just pattern recognition. They're not doctors, right? And he's swiping through, and they get to this picture, which you all can see looks similar to the original picture where we started. And then he reads that people that are exposed to the combination of lime juice and the sunlight get this rash. It's called bartender's dermatitis. It's also called phytophotodermatitis or Lyme rash as a lay term. So this is an incredible story because his cousin saw a healthcare provider that got it wrong. And he turned to her and said, you've been cutting limes? And he says, yeah, how did you know? And they're both not physicians. So, and it's really a cool story because this is a harmless kind of rash. I mean, you're not going to die from this rash, right? And you have people that are angry at doctors for making them wait an hour in the waiting room to pay a $40 copay to get there and get the wrong answer, to get a diagnostic error. And so we're at this inflection point in our society where doctors, because of fee-for-service medicine and because how complex medicine is and seeing such a high volume of patients, we cannot expect a family physician to know all of medicine. We can't expect an ER doctor to perform flawlessly, but I think the patients expect that. And especially if they wait an extra hour in the waiting room. So let me just wrap it up. Oh, this was from an entrepreneurial point of view. I'll thump my chest. Small companies love this kind of attention. So Tim Cook at Apple during the quarterly Apple investor call last November held this up as an example of machine learning on the iPhone. And the reason he did was Apple announced last year this technique called Core ML. And so what Core ML allows you to do is to port your machine learning algorithm onto the iPhone and process the image on the iPhone. So when we do those analysis, when I did the picture from Dr. Brown and you saw that progress bar is actually a dummy progress bar. It's not real. An iPhone 7 or newer analyzes that image in under 1/10 of a second. And when we first released the machine learning, the users didn't realize that machine learning had happened. So the designer put in this dummy progress bar that said analyzing image. Because people thought it was broken. They didn't think anything happened. So this is really incredible because to train the machine learning, they have these really fast computers. They have it digest 100,000 images. It takes like 2 days to create the machine learning model. It packages it up into a 100 megabyte file. They put it on the iPhone with this Core ML, and then it runs it in less than 1/10 of a second. It's really pretty amazing that you can do that on a smartphone, take a picture. And I think this is going to transform not just medicine, but I think already there are all these consumer apps around identifying plants and leaves and birds where you can do this. But the medical informatics piece of Core ML is it's great for privacy. So what it did for us, it ensures our clients that we don't have any HIPAA information. We have no pictures of patients in our server from our professional app. So the image gets analyzed and then the image gets dumped, never goes up to the cloud. We're able to tell our clients, don't worry, we don't have pictures of patients' faces because we don't have any pictures of any of your patients. It's happened all on the iPhone. And so patients are change agents, and that's a really important part of what we try to do. We really try to teach physicians about using technology to engage the patient. The patients are all on the internet before they visit with us. They're on Google, they're on WebMD, and a doctor looking up information in a database actually communicates to the patient, hey, she cared enough to look it up in front of me and to show me that she didn't just wing it, that she actually dug a little deeper. So we spent a lot of time trying to educate to this idea of using these tools with patients. And so this is just a slide about terminology. So sitting under the hood of both VisualDx and ASA is a technical platform for the knowledge base and the terminology. So on the left, it says consumer common search terms, aching joints, heart racing, small bumps on skin. And on the right, it says arthralgia, tachycardia, tiny papule. And so there's a concept-oriented relational database that we've developed, matching to SNOMED. We have consumer terms, we have professional terms, we've translated the interface and search terms and diagnosis names in VisualDx to Spanish, to French, to German, Mandarin, in a few months, Japanese and Portuguese. And if you develop with a relational database and you have a concept-oriented build, then you can do all that. And then you can scale it, right? So foundational, you have to set the right foundation in your informatics work, and I'm sure that's part of the teaching here. And I think that's part of our ability to move forward with ASA as quickly as we did, is all part of the same development platform. And so I think the AI and the clinician plus the patient will result in these benefits. And it's your generation that's going to fix all these problems that we have in healthcare. So thank you.
So I think what we'll do is we'll end the formal talk right now. If for those of you who want to leave, need to leave, feel free to do so. And then Dr. Papier is going to stick around, and everyone else is welcome to. We can ask him questions about this. We can ask him anything we want. But let me go ahead and turn the light. Actually, can you turn the lights up? Oh.